My name is Molly Dennis.
And my name's Brooke Zeliff.
And we're here to talk about whiplash-associated disorders.
By the end of this presentation, the audience will have a clear understanding of the following regarding whiplash-associated disorder, as we will refer for the rest of the presentation WAD. The definition, classification, diagnosis, prognosis, appropriate PT interventions, and outcome measures.
According to the Quebec Task Force, whiplash is an acceleration-deceleration mechanism of energy transfer to the neck, which may result in bony or soft tissue injuries, whiplash, which may in turn lead to a variety of clinical manifestations, or whiplash-associated disorders. The incidence of whiplash-associated disorders is estimated to be 1 million injuries annually in the U.S. Current data indicate that up to 50% of people who experience a whiplash injury will never fully recover, and up to 30% will remain moderately to severely disabled by their condition. Whiplash-associated disorders are a common and costly burden on the healthcare system. General signs and symptoms include, but are not limited to, neck pain or stiffness, arm pain and paresthesias, temporomandibular dysfunction, headache, shoulder pain, low back pain, visual disturbances, memory and concentration problems, and psychological distress.
The mechanism of injury for a WAD can include motor vehicle accidents, which is the most common, sporting injuries involving a blow to the head or neck or a heavy landing, pulls and thrusts on the arms, falls, landing on the trunk or shoulder. Extent of injuries depends on position of head at the point of impact, the amount of force involved, and direction of forces.
In a whiplash injury, the following structures may be affected: ligamentous, muscular, neurological, bony, or other connective tissue. A strain injury to the previous structure will result in secondary edema, hemorrhage, and/or inflammation.
The mechanism of injury, as pictured below, illustrates the events that happen during a whiplash injury: hyperflexion followed by hyperextension.
Diagnosis of whiplash injury is often difficult for the practitioner. There are no specific neuropsychological studies or electrophysiological tests that can diagnose whiplash injury. In other words, there is no gold standard in diagnosing whiplash-associated disorders. It is important to know the mechanism of injury. Injury is most often not identified radiographically in the acute phase. Most common radiograph findings are pre-existing degenerative disease or slight loss of normal lordotic curve of the cervical spine. Flexion extension x-rays at the time of injury may also reveal a kyphotic angle. At the time of initial presentation, MRI is not indicated because of high false positive results.
The Quebec Task Force was a task force sponsored by a public insurer in Canada. In 1995, the QTF developed the Quebec classification for whiplash-associated disorders. The authors proposed this classification system in order to facilitate the evaluation of research and to provide clinicians with useful guidelines for making decisions about therapeutic management. It classified patients with whiplash according to the type and severity of signs and symptoms observed shortly after the injury.
Whiplash is a complex, multifaceted disorder involving varying degrees of both physical and psychological disturbance. Sterling et al. Proposed a new classification system which reflects the complexity of the condition and is inclusive of identified specific impairments which the QTF classification has left out. In the new classification, whiplash-associated disorders type 2 has been expanded into 3 subgroups. These are the remaining 2 classifications for whiplash-associated disorders. Notice in Class 3 there are measures of psychological distress and post-traumatic stress, different than the Quebec classification system.
During the physical therapy examination, the physical therapist might find the following: upper motor neuron signs and symptoms, periodic loss of consciousness, patient does not move his or her neck, painful weakness of neck muscles, gentle traction and compression of the neck cause pain, severe muscle spasm, point tenderness on inflicted neck muscles, complaints of dizziness, limited neck range of motion, ligamentous instability. WAD falls under the preferred practice pattern 4E, which include the following: impaired joint mobility, motor function, impaired muscle performance, and impaired range of motion associated with localized inflammation.
The following should be ruled out during a differential diagnosis for WAD: cervical radiculopathy, fictitious disorder, polymyalgia rheumatica, traumatic brain injury, cervical herniated disc, cervical myelopathy, cervical osteoarthritis, infection or osteomyelitis, inflammatory rheumatologic disease, malingering, psychogenic pain disorder, referred pain from cardiothoracic structures, tumor or malignancy of cervical spine, and vascular abnormality of cervical structures. Special note should be made to those disorders that need to be referred out.
There has been much debate whether a soft cervical collar should be used following a whiplash injury. Most recent evidence shows that a soft collar is not useful and can hinder one's recovery. Current PT recommendation is through a conservative approach and includes the following: ice and electrical stimulation during first 48 to 72 hours. Range of motion exercises and pain-free ranges of flexion, rotation are initiated as early as possible to reduce the likelihood of hypermobility. Gentle cervical isometrics. After full range of motion is restored, begin aggressive strengthening of the cervical musculature. One can also strengthen the upper trapezius and scapular stabilizers with upper extremity exercises to avoid symptoms of neck pain. Mobilization of the neck, especially during the acute phase, should be used as well. Other interventions have been studied, but there has not been a lot of feedback since the initial investigation, including thoracic spine thrust manipulation and cognitive therapy components.
Prognosis for WAD patients depends on the severity. Most improve within 8 weeks, however, complete resolution is uncommon. If it persists longer than 6 to 8 weeks, flexion and extension radiographs are useful to look for instability.
There are two outcome measures used for WAD. The first outcome measure is the Neck Disability Index. It contains 10 items, 7 related to activities of daily living, 2 related to pain, 1 related to concentration. Each item is scored on a 0 to 5 scale, and the total score is expressed as a percentage. Higher scores correspond to greater disability. The minimal detectable change is 5. It has a moderate test-retest reliability. The ICC for test-retest reliability is 0.68. The MCID is a 19 to 20 percentage points. The second outcome measure is the patient-specific functional scale. It asks patients to list 3 activities that are difficult as a result of their symptom, injury, or disorder. The patient rates each activity on a scale of 0 to 10. 0 represents inability to perform the activity. 10 represents the ability to perform the activity as well as they could prior to the onset of symptoms. The 3 activity scores are averaged for a final score. The ICC test-retest reliability in patients with cervical radiculopathy is 0.82. The MCID for this outcome measure is 2 points.
Thank you for listening to our presentation on whiplash-associated disorders. For more information, here is a list of our references.